Hello everyone and welcome back to Well Talks. I am Dr. Anvi Vaidia and joining us today is one of Kansas City's most renowned cardiologists, Dr. James O'Keefe. Dr. O'Keefe is a professor of medicine at the University of Missouri, Kansas City. He is also the director of preventive cardiology at the St. Luke's Health System and a chief medical officer at Cardiologist. Dr. O'Keefe is a very well-published author and a researcher, and we are very fortunate to have him today to talk about myocardial infarction. Welcome, Dr. O'Keefe.
Thanks, Anvi.
How are you doing today?
Doing well, thanks. It's Friday. It's the holidays. Things are good.
Yes, I'm sure most of our viewers today know you very well. You being so well-published in all possible journals. You've talked a lot about your research. His research has been focused on vitamin D and omega-3 fish oil. But let's start talking about myocardial infarction first, and then we will get to the research side of it.
Right.
So would you like to brief our audience a little bit about what is myocardial infarction?
Well, of course, myocardial infarction is necrosis of part of the myocardium. Generally, in the Western societies, this is caused by interruption of the blood flow with coronary artery disease. It still is a very prevalent disease. We know how to prevent it, but lots of times it sneaks up on people. So to keep things short and simple, you need to just focus on two things when talking about myocardial infarction. That is the resting ECG and the troponin levels. Okay? And this is pretty easy. Like if the troponin is above, say, 0.05 in our lab, if it's in the abnormal range, we call that there's myocardial infarction. If it is caused by a primary coronary event, we call it a type 1 myocardial infarction. Often it's a STEMI if we see ST segment elevation, so that's where the ECG comes in. You look at the ECG, if there's ST segment elevation more than 2 millimeters in 2 or more adjacent leads, and we call that a STEMI. And actually, to be honest with you, lots of times, even if before the troponin's up, if we see that telltale ST segment elevation, we rush that patient to the cath lab. But it gets more subtle with the troponins because the troponins are so sensitive, they're often up a little bit. And at that point, we have to make a decision about if they have ongoing chest pain, we'll take them to the cath lab. But if we can get it under control with the heparin, nitroglycerin, beta blocker, statin, the whole concoction, we try to settle things down. And then if it looks like this is acute coronary syndrome or a recent unstable angina or non-ST segment elevation infarction, we go to the cath lab, sometime in the next 24 hours and revascularize the lesion if it needs to be. But it is tricky about the type 2 non-STEMI. Okay. These are people that maybe come in with an anemia of 6 grams of hemoglobin, or hypertensive urgency with a blood pressure of 200 over 120, or maybe they had sepsis, or they just had a big surgery, or they had AFib with rapid ventricular response. It's a mismatch between the supply of blood to the myocardium and the demand from the myocardium that's working extra hard. And a type 2 non-STEMI is a very heterogeneous bunch, and so you have to kind of play that by ear. But the take-home message is look at the ECG, look at their troponin. If their troponin's not up, they're having chest pain, and their ECG is not worrisome, those are the people we do stress tests on.
Okay.
Usually a stress imaging test. But if the troponin's up and they're a candidate for revascularization, we either take them to the cath lab sooner or later, depending on their clinical scene and their ST segments on the ECG.
That is a great summary. Actually, I've covered a lot of myocardial infarction just in our first little talk. However, I would also like to ask you, you've mentioned troponin elevation. What is the normal level for troponins, and what would you call elevated enough where you might consider?
So Anvi, that's a little bit of a tricky question because troponins are specific to the type of troponin, troponin I, troponin T, which lab, what their reference range is. In our lab at St. Luke's, a normal troponin is less than 0.04.
Oh, okay.
Yeah, and so below that, we don't feel obligated to call this suspected acute coronary syndrome. And the higher it is, the more likely it is that they have real disease. But it's a pretty darn specific test. Sometimes people with chronic kidney disease will have a troponin that trends up, even stays up chronically, like 0.07 or 0.10, just from the chronic kidney disease. But generally, especially if you see it above 1.0, that's really uncommon to see that as a false positive. Now, it could be, doesn't have to be acute coronary syndrome. It could be myopericarditis. It could be this, type 2 non-STEMI from demand as well.
Right.
But
Right. And then,
very important blood test. Yeah.
absolutely. And now we are talking about labs right now, which is more of the diagnostic testing to make sure that it is an MI or a myocardial infarction. But say if a patient presents to the clinic or to the ER with certain signs and symptoms, how do we predict whether it is an MI or myocardial infarction, or if it is something else, if it is acid reflux, or how would you recommend the tests for MI itself?
Well, to rule out MI, it always, the fundamentals are a good history and physical. If it's a young, healthy woman like yourself, I mean, acute MI would be way down the list if you came in for chest pain. On the other hand, you have a middle-aged or elderly male with classic angina, we generally have a very high index of suspicion. But again, we really focus, the two main pivot points in the ER are the troponin and the ECG.
Okay.
And so when we see ST segment elevation, that's a siren. I mean, we hustle them to the cath lab right away. I mean, especially if it's that, concave upward, we call it across the precordium, sometimes we call it the tombstone look. Very, very worrisome sign. But troponin also are the keys, and the higher the troponin, the more we worry about it. If they have a negative troponin, unless they're very early in the course of their infarct, that troponin comes up within 30 to 60 minutes. So.
Oh, wow. So we talked about troponins, we talked about ECGs or EKGs. What are some other diagnostic tests that could be useful in these situations?
Well, honestly, there's the CK and the CKMB and that kind of stuff, but they're sort of obsolete most of the time because the troponin is so sensitive and specific that we really keep it simple and stick with the troponin.
Oh, wow. So that test itself can determine what kind of treatment the patient would need?
Yep. We use that as the triage point. If the troponin's negative, we rarely send them to the cath lab.
Okay.
If the troponin's positive, we usually send them to the cath lab unless there's mitigating circumstances,
Right.
elderly, do not resuscitate, renal failure, various things like that.
Great. How would you recommend a stress test? Is that important?
So yeah, we use stress tests a lot, and they're generally for people who have chest pain that we're not sure about. And again, we sort of choose the stress test to match the specific situation. So somebody who we're very worried about may have multivessel disease. We need to know specifics about perfusion in different areas. We usually go with a stress nuclear perfusion or a stress PET perfusion study. Somebody who's in the intermediate range, we often go with stress echo. We generally require them to be able to walk on a treadmill to be able to do a stress echo. And for very low-risk people, we often will just do a treadmill exercise test. So come up to a ECG and have them run on a treadmill, which is sort of modestly accurate. It often gives us false positive and false negative studies. Do you know, Anvi, a really useful test that has just finally, we've been endorsing this test for decades. It's one of our favorites. We've done hundreds of thousands of these in the last 20 years. But it's a simple high-speed CT scan of the heart looking for calcified coronary plaque. We call it a cardioscan. It's calcium scoring. Coronary arteries should be soft and supple and smooth and free from any calcifications. And when you start getting chronic atherosclerosis, it calcifies up. And so when we see a calcium score above 0, we know that they've had some plaque. And the higher the score, the more plaque they have. So it's a $50 test. It's a very low dose radiation with these high-speed rapid CTs. So we use that a lot. Again, say if a young person comes in with funny chest pain, lots of times I'll do a CT scan just because it is so sensitive. If you have coronary disease, significant, clinically important coronary disease, 98% of the time, you're going to have a calcium score above 0. And the higher the score, the more high risk you are for future cardiac events. So it's a real simple test we use a lot of.
That is great. So we did learn about troponins. We learned about EKGs a little bit. We learned about cardio scans, stress tests. So we have an array of tests to really determine whether somebody has a myocardial infarction event or not. What would be some of the treatment modalities for someone with a myocardial infarction, and are there different treatment modalities according to the severity of the event?
So Anvi, the treatment of acute myocardial infarction, in fact, was invented at the Mid-America Heart Institute by Dr. Jeffrey Hartzler and Dr. Barry Rutherford in 1981.
Wow.
And they took a patient with an involving inferior infarction. They'd done an angiogram on him earlier that day, high-grade subtotal RCA lesion. Patient started getting chest pain in the hospital room a few hours later. Looked at the ECG, got these big ST segment elevations in the inferior leads. They said, he's having an infarct. Why? It seems so logical now. Let's take him to the lab and open this up. We know what it is. So they went in there with these very rudimentary balloon devices, and they got it open. The chest pain went away. The ST segments came down. The patient's happy again. They said, wow. And literally, the cardiologists in the 80s at St. Luke's Hospital in Kansas City were the ones who really pushed that agenda and proved that this is the most effective way to treat acute myocardial infarction. So, in the 21st century in America, the way we deal with acute myocardial infarction is take them to the cath lab. It's so effective. There is, thrombolytic therapy. Like, I've been a cardiologist for, over 30 years, and I've only used thrombolytics once because we always have a cath lab person available to do this. So that's the simple answer. Get them to the cath lab. You think they're having an acute infarction.
Are there any contraindications going to the cath lab?
Not many. If you can get access, and these days our interventional cardiologists often use the wrist, the groins. It's a pretty universally. If they're teetering on the brink of end-stage renal disease and they're trying to avoid hemodialysis, sometimes we think twice. But because it's such a life-threatening condition, we generally take them to the cath lab.
Wonderful. And then finally, what would be, one, the assessment of treatment, and two, how do we maintain after somebody has gone through myocardial infarction, treated successfully? Now we want to make sure that this event does not ever happen again.
Yeah.
How do we prevent that?
Well, so the prevention of acute myocardial infarction is kind of the area of expertise that I focus on, and a coronary disease, Anvi, is largely a medically preventable disease these days. If you're paying attention, we know getting lipids down with statins, now PCSK9 inhibitors, using high-dose omega-3, aspirin, beta blockers. Lots of times we use angiotensin receptor blockers or an ACE inhibitor to control blood pressure and improve outcomes. And cardiac rehab and beyond that, exercise, very effective. We know that diet is effective as well, eliminating sugar. We use aspirin. We use DAPT, dual antiplatelet therapy, for the first year after a drug-eluting stent, generally. So it's a complex thing. We focus on getting people off of tobacco, but it's highly effective, and especially when we get that LDL below 70 or 50 milligrams per deciliter, it's hard to make plaque. So it's a very effective way to prevent events.
And then how many, or what would be the frequency for someone that has gone through myocardial infarction to come in and do the required testing, like EKGs and troponins?
Oh, we used to bring people in like once a year to do stress testing and all that kind of stuff. We are so confident these days that we know how to prevent this disease. Like somebody comes in, gets a stent. Lots of times we won't do another stress test for 5 years.
Oh, wow.
Yeah. This works. This really works. We know how to prevent it. If they're stopping smoking, taking their medications, coming in for their cholesterol checks, they do fine. We never do repeat look angiograms unless there is some complication or something. But no, this is a very predictable sequence. Yeah.
That is incredible. That is incredible. Having 5 years free of testing is just incredible.
Yeah.
Well, to our students here, I'm sure you got a lot of information today from the guru himself. So I really hope you enjoyed this. Thank you, Dr. O'Keefe, for taking the time to talk about myocardial infarction with us. And thank you to the Henry W. Block School of Management for letting us film here. Thank you very much. Join us for our next video with Dr. O'Keefe about his own research on omega-3 fish oil and vitamin D. Thank you very much. See you again soon.